Kumar, I met him. I have not seen Francis. Can you switch on your camera and show your face, Francis? Okay. Are you a primary candidate or a post-DA candidate?
Sir, I'm post-DA candidate, sir.
Where did you do your PA?
Sir, I did in Karnataka, sir, in Bellary.
Bellary. Okay. Oh. Fantastic. Very good. Then who are the other? I think all the other names are familiar. Kyle, Bindu, they are all seniors. Okay. Only two of you, the new batch.
Sir, two more people are there.
Two more girls are there, sir.
Huh?
Two more people are there, sir.
Two more girls are there. Okay.
One
Are
case is going, so they are in the OT, sir.
OT. Okay, no problem. Right. So, shall we start, Kamachi?
Yes, sir. Yes, sir. Please, sir. Good evening, respected professor. My dear students, I welcome you to the third session of Basic Sciences of Anesthesiology. Today, professor will be covering the second part of respiratory system. Over to professor and students. Thank you, sir. Please.
Thank you very much. And I hope the last discussion on respiratory system, we covered the anatomy, 4 questions, commonly repeatedly asked questions. And then we covered part of the physiology where the regulation of respiration we discussed a little in detail. And all of you should have got a basic concept how the neural and chemical control of respiration takes place in our body. And adding on further to the respiratory physiology, we have to learn something more, which, as I mentioned in the last class, I feel a little gray area for the students to understand, because it involves a lot of physics principles rather than physiology principles. Okay, so the so-called mechanics of respiration. So we have seen the structures in the anatomy which are responsible for our respiratory function, and we have seen how our respiratory function is controlled. The alternate inhalation and exhalation functions are controlled by the neural and chemical mechanisms. Now we are going to deal with the mechanics of respiration, how the air moves in and out of the respiratory tract. What are the factors which help the airflow from the atmosphere into the terminal part of the respiratory system, namely the alveoli, where ultimately the gas exchange has to take place. Oxygen to be taken in and carbon dioxide to be eliminated. So during that transport of the atmospheric air containing oxygen, what are all the factors which affect that flow, and how to enhance that flow and achieve the maximum benefit out of that respiratory activity. That is what we are going to see. So I'll just share my screen with you. Is it clear?
Yes, sir.
Yes, sir.
Yes, sir.
So this picture must be very familiar to all of you. What is shown here in these pictures?
Lung
Everything
volume
is
and
written
capacity.
there. Lung volume.
Lung volume and capacity.
Very good. Why there are two different things? Why cannot it be the entire capacity? Why not it be our entire volumes? What are the 4 volumes that we normally speak about when we talk about the mechanics of respiration?
Vital volume, expiratory reserve, inspiratory reserve, and residual volume.
Residual volume. So there are 4 volumes. But capacities, are they all measured or they are derived?
Derived from the volume, sir.
Many of them are derived. They are nothing but combination of your volumes. So capacities are nothing but the combination of 2 or 3 volumes together. And which capacity is measured which can be measured in actually in the pulmonology lab or respiratory lab. Which are all the
Vital
capacities
capacity?
we can
Vital capacity?
we can measure vital capacity. Very good. And then can you measure functional residual capacity?
No, sir.
No? Who said no? Hiranmayi?
Soundarya, sir.
Soundarya. Okay. You cannot measure FRC? Okay. We'll see how it is. So, what are volume and capacities of a normal lung? There are 4 measured volumes, like the tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. And there are 4 capacities, which are nothing but addition of 2 or more volumes, like inspiratory capacity, which is a combination of tidal volume and inspiratory reserve volume. FRC, which is a combination of ERV and RV, and vital capacity, PV, IRV, and ERV. And total capacity is a combination of all the 4 volumes. Okay. Now I am going to show you a few instruments which are used to measure this. And can you name? I think I have shown the names also, but have you all seen this particular instrument?
No, sir.
No, sir.
No, but the name is given. This is the first instrument it is given here. It is called the Wright's respirometer. I showed you this picture in one of the OSCE classes earlier. And I showed you what is these 2 buttons are for, how is the dial marked or arranged here. Okay. So there are 2 dials. Can you see 2 separate ones? I have shown it in close-up view also. Okay. So there are actually 2 dials inside with 2 pointers. Are you all able to see those 2 pointers? One long pointer and one small pointer?
Yes, sir.
Yes. So the outer dial, if you see closely, it is divided into, the 1 liter is divided into 100, 200, 300 like that, or 0.1, 0.2 like that. So the outer dial measures the smaller volume. Which is the smaller volume? What is tidal volume? Why it is called tidal volume?
Breathing pattern.
It's normal, quiet breathing, sir.
Normal, quiet breathing. See, you must always develop the habit of telling a definition. Whenever a question like this is asked in the examination, they may ask you, especially if they ask you about the pulmonary function test. This is one of the important values they will ask you. This is the tidal volume. Tidal volume is the amount of air breathed in or breathed out. Any one. It is not a combination of both. So amount of air breathed in or breathed out during a normal quiet respiration. That is called the tidal volume. But why it is called tidal volume? Why cannot be called as inspiratory volume or expiratory volume? Now, if you see this picture, you will get the answer. See, this is the tidal volume which has been measured here. This is probably the inspiration, this is expiration, inspiration, expiration. So when you plot it like that, how does it look like? A continuous plotting of the inspiratory and expiratory volumes. It looks like a wave of a sea, isn't it? A tidal wave of a sea. That is the reason why it is called tidal volume. Okay. So tidal volume by definition is the amount of air breathed in or breathed out during a normal quiet respiration. And after breathing a normal volume of air, if you desire to inhale more, you can inhale more also. That is called inspiratory reserve volume. By willfully making effort, you can add little more volume to your inspiration. So that is called the inspiratory reserve volume. Similarly, after the now small amount of air that you exhale during a quiet breathing, If you make efforts, you can blow out some more air or exhale some more air, which is called the expiratory reserve volume. But there is a small amount of air which is left in the lung, because the lungs will not totally collapse after an expiration and re-expand again during inhalation. So whatever amount of air is present after even a forceful exhalation is called the residual volume. Why nature has made it in such a way that there should be always some amount of air present in the alveoli even after your expiration or exhalation?
To prevent alveoli from getting fully collapsed.
Fully collapse. Why? After all, they can collapse and then re-expand, isn't it?
To open up a fully collapsed alveoli, we need more pressure than to open up a alveoli which is already having some amount.
Partially filled. Fantastic. Very good. That is the prevent the excessive work of breathing required to expand the totally collapsed alveoli. That is one purpose. Very good. Is there any other role for that? Now, this residual volume combined with functional residual capacity or added with the expiratory reserve volume, what does this do? These two together, the RV and ERV together, we call it as FRC. So FRC, RV is also a part of it. So what is the function of this residual capacity, where this amount of air which you can forcefully exhale out is also there inside?
It is a reserve of the lungs in case patient has to go in for a period of apnea or something. To prevent desaturation, this functional residual capacity will help.
So do you go for apnea on and off?
No, sir.
Can anyone else give the explanation? What is the function of that residual capacity? Residual means there is something left out. Residual volume and residual capacity both mean there is some air of residual air left in the lung even after expiration. So is it there only to subserve your apneic spells? Do we all develop apneic spells on and off? No. The purpose of that is to supply oxygen during the small interval of expiration. Okay. See, when you do a respiratory activity, inhalation or inspiration makes the air from the atmosphere flow into your lungs and reach up to the alveoli, where oxygen is taken up because of the pressure gradient or pressure difference. What is the pressure gradient or pressure of the pulmonary venous blood that is coming to the alveolar capillaries? How much of pressure of oxygen is there in the pulmonary venous capillaries which are coming close to the alveoli? After all the oxygen has been delivered to the tissues, the venous blood or deoxygenated blood from the various parts of the body is brought to the lung to again fill it up with oxygen. Every breath subserves the function of oxygenation. So that comes at a pressure of 40 millimeters of mercury. And in your alveoli, what is the oxygen pressure of oxygen in the alveolar air? It's about 105 millimeters of mercury, because we will come to that alveolar equation and other things. We will have to learn about that. That will tell you that alveolar oxygen pressure is higher and venous oxygen pressure, venous capillary, pulmonary capillary oxygen pressure is lower. So there is a pressure gradient. So oxygen travels because of the area from higher pressure to lower pressure. Okay. That will automatically happen through the inspiratory phase of the respiration. But after that, what happens? Similarly, because of the pressure gradient, atmospheric air in the alveoli has zero or negative or no pressure of carbon dioxide. Whereas the carbon dioxide pressure in the venous blood is about 40 millimeters of mercury or 45 millimeters of mercury. So because of that pressure gradient, again, carbon dioxide will pass through the alveolar capillary membrane into the alveoli, and this has to be expelled out. So during the time of expiration, every breath, there is a period where heart is still pumping and blood is constantly flowing. So to subserve that period of expiration, you require some amount of air left in the alveoli to give the body oxygenation, because the cardiac cycle is a continuous process. It pumps blood continuously from the heart into the lungs, into the various tissues. Okay, so the functional residual capacity only helps you to get oxygenated continuously even during the period of exhalation or expiration, and that is the way it is called functional residual capacity. Okay, so then there is another capacity which is very, very important, and that is the way the name has been given as vital capacity. Why it is called vital capacity? The name itself is self-explanatory. Vital means very important. So it is a very important capacity. What way it is very important?
It is vital to exhale out any foreign bodies caught in the lung.
Prevent aspiration. Fantastic. Very good. So the combination of these three volumes, expiratory reserve volume, tidal volume, and inspiratory reserve volume, all the three put together is called vital capacity. This is very, very vital because your ability to cough and clear your secretions or prevent any aspiration of foreign material into your respiratory tract will be powerful only if you have a normal vital capacity. If your vital capacity is decreased, then your ability to cough, ability to prevent aspiration will be lost, and you will be drowning in your own secretions, because you know our upper airway has a lot of secretions constantly to humidify the gases, and that secretions will all collect up. Because we have a mild ability to cough and clear our throat on and off, we are not feeling any aspiratory effects. But if your vital capacity, if you are debilitated, sick, if your patient is in ICU for a long time, he has been ventilated, he has not had enough nutrition to have a normal muscle activity, these people all will have a reduced vital capacity, and they are prone for aspiration and retention of secretions, which can lead to atelectasis, pneumonia formation, and all those things. And that is the reason why they have given the name vital capacity for this particular capacity of the lung. Now, this picture, what is being done here? What are they measuring? I have already given the names, so you can guess the names from here. What is written here?
Spirometer.
Spirometer or spirometry. Okay, so you ask the patient to inhale deeply and then blow out, and it should be blown out only through the mouth, through the mouthpiece. And so to prevent any air flowing from the nose, what have they done? Can you see that in the picture? Is it clear? They have put a clip to close the nose. Okay, so all the air should be only blown out through the mouthpiece into the machine, and it will automatically record. This is a modern bedside spirometry machine, and the measures we are able to do with that are, we can measure tidal volume, we can measure inspiratory reserve volume, we can measure respiratory reserve volume, which will all give a vital capacity. Okay, so these are all the volumes and capacities which can be measured using this particular instrument. This is the older type of spirometer where patient will be able to blow, and there will be a water jug, all these things. I have given this picture for you to know this, so that in case they ask this machine in the OSCE classes, then you should be able to identify. This is an older type of spirometry machine, where in the pulmonology lab you will have a drum like this filled with water, and whatever air you blow, it will collect here and press the water, and there will be a pointer which will go on drawing in a drum. So this is an older type of pyrometer. Now that has been replaced with these modern sleek machines which can be used at the bedside. And this is the last one which is given here. Body plethysmograph. Okay. This is the one which you can use to find out the functional residual capacity, how you will be seeing in the subsequent slides. So these are all the common instruments that are being used in the measurement of tidal volume, I mean the various volumes and capacities. Okay. Now going on to that, now we have come, already we have talked about FRC and what is the role of FRC. So there are two functions for FRC. One is to supply oxygen during the period of expiration also. The second is to partially keep the alveoli open so that there is not much of effort needed to fill them up again during the next respiration or inspiration. Okay, these are the two primary functions of the functional residual capacity. Now you must know which factors will affect that and what will happen if the FRC decreases. Can you tell me which factors affect the normal quantity of FRC? All of you should be able to say how much will be the volume in, say, in ml and liters of various volumes and capacities. So normal adult tidal volume is about 400 to 600 ml. For men, it is about 500 to 600. Women, it is about 400 to 500. And the inspiratory reserve volume, expiratory reserve volume, vital capacity is about 2 to 2.5 liters. That means tidal plus IRV plus ERV all put together is about vital capacity. And total capacity of the lung is roughly 5 liters. Which is, you can remember, like cardiac output 5 liters, this is also 5 liters total capacity. Okay, but what factors affect the FRC? This is one of the common questions in the examination.
So positioning,
Very
age
good.
or obese patients, pregnancy also
General
will decrease.
Okay.
Pediatrics,
Age,
So you can remember a mnemonic for that.
restrictive disease.
All of you heard of bangos? What is bangos? BANGOS. None of you interested in music? Western music or West Indies music? Have you ever seen a West Indies music being played? They keep a twin drum between the knees and then tap on that. That's called the bangos, no? So instead of that, you remember pangos. Replace that B for Bombay into P for Patna. PANGOS, pangos. It's a mnemonic to remember. P for pregnancy, A for
Age.
ascites, N for neonate, G for GA, general anesthesia, O for obesity, and S for surgery, upper abdominal surgery. Okay, these are 6 conditions will cause a reduction in FRC. Pregnant patients have a reduction in FRC. That is why they desaturate faster. That is the reason why whenever you give anesthesia for a pregnant woman, you must do adequate pre-oxygenation to prevent the patient going in for desaturation. So pregnancy, ascites, that splints the diaphragm, does not allow it to come down. So naturally, the volume of air that is left in the lung after expiration will be reduced. Neonates, they don't have enough FRC. That is why they also desaturate faster. General anesthesia, that also causes relaxation of the diaphragm and pushing up of the abdominal content, that also reduces FRC. Obesity, that also spins the diaphragm, pushes the abdomen, intra-abdominal pressure is increased, so that also reduces the FRC. And surgery in the upper abdomen, which causes splinting of the diaphragm, that also causes decrease in the FRC. So PANGOS, pangos, instead of bangos, you remember pangos. So factors causing, which factors will increase the FRC? What decreases I have said? What are the factors which increase FRC?
Standing position.
Standing position. Okay.
Right.
Patient.
Height of the patient. Very good. Okay. Taller the patient, more the FRC. Good. Then one important condition, pathological condition rather. It is not physiological. COPD. I thought you will all be shooting the answer immediately because there is always an airway obstruction. So more and more gets trapped inside the lung. So FRC will be naturally more in patients with COPD. So increases slightly with age due to loss of elasticity in connective tissue. Increases in debilitated patients. Lungs do not return to normal size after expiration. Tall person has a larger lung volume and a greater FRC, and men tend to have slightly larger lung volume compared to women because of the height and the age. And also COPD patients in pathological conditions, there will be more wrapping residual air. And what else? Decreasing, change in position from supine to lateral or prone, pregnancy, ascites and obesity, general anesthesia, neonate and surgery. So this is the mnemonic under which I told you to remember all these things. And reduction in FRC promotes airway closure in the dependent lung regions. Okay, that is another factor which causes. So if the airways close earlier in the dependent lungs, what will happen? Because of the reduction in FRC. That will lead to lung blood flow passes preferentially to dependent regions. So matching between ventilation and perfusion will be impeded, and this may result in PQ mismatch or perfusion ventilation mismatch can happen. So this is the picture. What test is performed here and what gas law is utilized in performance of this test. So here, this is what is called the body plethysmography. Okay, and it involves what is called the Boyle's law. There are three basic gas laws. As I told you, the mechanics of respiration involves a lot of physics. So the basic gas laws. What are the three basic gas laws? Boyle's law, Charles law, and Gay-Lussac's law. Okay, all whatever you have studied in your school final, you have to recall all these things when you study respiratory system. Okay, so Boyle's law, pressure and volume are inversely proportional at a constant temperature. So how is it utilized here? Patient is placed in a closed box with a mouthpiece that exists in here. So here is the mouthpiece. Again, you can see patient's nostrils are closed with a clip, and he has to blow through that. There is a connector taking to the machine outside. So patient inhales against a closed mouthpiece. When the patient inhales, the volume of gas in the box decreases and the patient takes up more space. Therefore, the pressure increases. So measurement of FRC by body plethysmography is based on the application of Boyle's law, which is usually P1 into V1 is equal to P2 into V2. So you can find out this. So Soundarya, you have to remember the concept that body plethysmography can be used to measure the FRC by this particular procedure. Okay? Yes. Right. So what is lung compliance and what factors affect that? So those are the things you have to remember from examination point of view with FRC. So one of the important things that we have to remember for our practical points application also. Now, lung compliance and what factors affect it. What is the definition of lung compliance?
Change in volume per unit change in volume.
Fantastic. Whenever you apply pressure, you can increase the volume because this is an elastic structure. The alveoli is an elastic structure. So if you apply more pressure, you can increase the volume that the alveoli can hold. Okay, so pulmonary compliance is a measure of the expansion of the lung. It is critical for the proper functioning of the respiratory system, and it is calculated by the volume by pressure. Change in volume divided by the change in pressure gives you the compliance of the lung. And of course, if you read the books, they will talk about what are all the structures which are compliant in the thoracic cage, which has to be taken into consideration for a proper inflation of the lungs. First of all, alveoli, imagine like a balloon. So they have to be quite compliant, isn't it? If all of you would have seen balloons with the thicker wall, outer wall, and the thinner wall, which are being used for decorating a birthday party or any function. So which is easier to blow? A balloon with a thicker wall or a balloon with a thinner wall?
Thinner wall.
Thinner wall. So compliance will be more easily stretchable. It should be stretchable, isn't it? So that is the first thing, compliance of the alveoli. But they are not open to the atmosphere. They are enclosed in the thoracic cavity. So there is a chest wall compliance. The thorax is made up of your ribs and your muscles. So they should also become compliant. Whenever you want to inflate the alveoli within the thoracic cage, the chest wall also should expand so that the alveoli can expand nicely inside. So both the things have to be compliant. And the factors affecting the lung or the alveolar compliance include the elasticity, which is made up of elastin, which is a connective tissue. And the second important factor is the surface tension in the inside the alveolar cavity. Okay. So these two are the important factors governing the lung compliance of the alveoli. And certain pulmonary diseases can affect the lung compliance, which you will all be knowing, especially emphysema and COPD. In both these conditions, the elastic recoil property suffers a damage. It may be because of the genetic cause like deficiency of alpha-1 antitrypsin, or it may be an extrinsic factor like smoking. And because of that, the poor elastic recoil, they become more compliant. They expand more, but they are not able to come back to the normal original level. But factors which will reduce their expandability are pulmonary fibrosis and newborn respiratory distress syndrome and atelectasis or ARDS. These three factors will reduce the compliance, whereas COPD increases the compliance. So whenever the compliance is reduced, your FRC will be reduced. Whenever the compliance is more, FRC will be more because of more residual volume. So the above three conditions decrease the lung compliance. And there is another terminology which you have to know, which is called elastance. And how is it important? So we saw that compliance means expandability of the alveoli and chest wall. That is compliance, as simple as that. But what is elastance?
Ability to recoil.
It is the opposite of your compliance. So elastance, also known as elastic resistance, is a reciprocal of your compliance. The pressure change that is required to elicit a unit change in lung volume. So this is a measure of the resistance of the system to expand also. So elastance is a measure of the work that has to be exerted by the muscles of inspiration to expand the lungs, and the pressure that you have to exert is called the elastance. Okay. So compliance is the increase in volume due to pressure change, whereas elastance is the opposite. Here, instead of putting V here, if you put P, change in pressure due to change in volume, it will become elastance. So the opposite of compliance formula is the formula for elastance. Okay. And elastance is 1 by compliance or pressure change by volume change. So these are the two important factors for a normal expansion of the lung. Now, what modifications was done in, there is an equation called Bohr equation. By whom was it done and why was it done? Have you all heard of Bohr equation?
Yes, sir. Enghoff's modification, sir.
Enghoff modification. Very good. What is the modification? What is first of all Bohr equation? This is one of the short note questions that can come in your theory paper also. Bohr equation in 1938 and recognized the problem of obtaining an appropriate estimate of alveolar PaCO2. P capital ACO2 means alveolar capital carbon dioxide level or tension. Of the Bohr equation, Enghoff, the person who proposed a substitution of the arterial carbon dioxide instead of the alveolar carbon dioxide. So first of all, you must know what is a Bohr equation. Bohr equation is a method of identifying the ratio of the tidal volume to the dead space. Now we will be seeing soon what is a dead space and what is the importance of that. So VD stands for volume of dead space, VT stands for volume of tidal volume. So VD by VT is equal to, earlier it was PA capital A CO2 minus expired CO2 divided by again PA CO2. That was the original Bohr equation. But because measuring the exact amount of carbon dioxide in the lung means you have to put a catheter into the alveoli, measure what is the pressure of carbon dioxide there and do that. So instead they found that once they got the blood gas machine, they thought they were able to correlate the relationship between the arterial carbon dioxide and the alveolar carbon dioxide, and that gave the modification. So the Enghoff modification of dead space calculation is a general use today and described as the physiological dead space, which term which is sum of anatomic dead space and alveolar dead space, which we will be now seeing very soon. And the current usage of alveolar dead space component is definitely defined by the difference between the physiological dead space and anatomical dead space. So the Bohr equation is nothing but an equation used to calculate the anatomical dead space. That is what you have to ultimately remember. So Bohr equation. Is there any other contribution by this Bohr, BOHR Bohr fellow?
Double Bohr effect.
Double Bohr effect. Very good. So there are so many things. He is a very brilliant guy. His father also was a doctor in Sweden. So this fellow has a lot of contributions in medicine. Okay? The double Bohr effect is also very important. So the mean alveolar carbon dioxide is always less than mean PaCO2, and that is the objection raised by a few people, but the difference is quite small. So you can substitute the alveolar carbon dioxide value to arterial carbon dioxide and calculate that. So just as any gas exchange abnormal will increase the alveolar arterial oxygen difference, the same statement holds good for arterial alveolar carbon dioxide difference also. But for all practical purposes, this formula can be used for assessing the amount of dead space ventilation. Now, how dead space happens in ARDS? It's one of the conditions all of you would have seen commonly 2 years ago when COVID was rampant, and many patients had very severe mortality because of the ARDS that was set in by the COVID infection. So what exactly happens in ARDS and how this dead space affects the persons with ARDS? The abnormal measurement was due to regions of blocked microcirculation. That is the basic thing in this. So when there is no blood flow in the capillaries, but they remain, the alveoli are getting ventilated. So in what happens? There is a wasted ventilation. Alveoli is inflated with adequate air or oxygen, but the capillary circulation is not there to take up that oxygen. So what happens? There is a true alveolar dead space secondary to the creation of this obstruction. So in addition to that, there is also variations in the alveolar ventilation perfusion mismatch also was ubiquitously present all over the lung. Both of them cause dead space. Now, before discussing all this, actually I should have asked the question, what is dead space? What is your idea or concept of dead space?
Air that doesn't take part in gas exchange.
It is a part of or volume of air that is not taking place in gas exchange. That is, giving up the oxygen and taking up the carbon dioxide from the body. That is called gas exchange. So that portion of the ventilation which is not doing that function of a gas exchange is called dead space. Where exactly this amount of gas is present which is not taking place in the gas exchange?
Conducting
Which are all the
airways.
regions?
Conducting airways.
Conducting airways.
Conducting airways. Very good. So all of you remember that we had a Weibel's classification of 23 generations. I told you in the earlier class the various generations where the tracheobronchial tree is dividing into, right, starting from trachea up to the alveoli. Okay. So out of these 23 generations, we saw there about 17 to 19, about 17 up to 17 generation, air purely just comes and goes. It is a traveling passage. There is no gas exchange at all. And from 17 to 21 or even 19, there is a transitional zone where some amount of gas exchange takes place through the alveolar sacs, but not due to the alveoli. And then from 19 to 23, it is a purely respiratory zone where classical gas exchange is taking place. So all the air that is present above the 17th generation, they are just mere conduits or passages for the air, and there is no actual gas exchange happening. And that volume of air is supposed to be called as dead space gas because it is not taking place in any gas exchange. And how do you calculate that? That is the reason why Bohr found out this particular equation to find out how much of wasted or dead space gas is there in our respiration, so that we can try to reduce that so that maximum gas can be utilized. So roughly, if an adult has 500 ml of tidal volume, how much will be the dead space gas? What will be the volume?
150.
Roughly about 150. Okay, so only 2/3 of the 500 ml, 350 ml will be taking place in gas exchange, and 150 merely comes and goes. And that is the reason why we are using our circle system. What is the concept of circle and system anesthesia, where we remove the carbon dioxide and reuse the exhaled air, because the anatomical dead space air is as good as your fresh air or the non-used air. The same content of oxygen and carbon dioxide will be there in the dead space gas because nothing is getting exchanged. So if you can reutilize that, you can reduce the amount of gas that is required to anesthetize the patient. And the concept of circle system came because of that particular concept, that your dead space gas is as good as a fresh gas. And dead space gas is also used to find out whether the how much of alveolar gas is left in the lung. Residual volume or the FRC also can be measured by using a gas which can dissolve and go up to the alveoli, and when they come back, some of them would have been absorbed and some of them will come out. So you can exactly calculate the amount of alveolar ventilation gas also using the dead space. Okay, so these are the two advantages of knowing about the dead space. Now, what is lung dead space? How is it classified? How is it calculated? So this is another common question. What is lung dead space? We have already mentioned the gas that is not taking place in the gas exchange. What is the classification? Whatever is present in the tracheobronchial tree up to 17th generation, it is called anatomical dead space. What is physiological dead space?
Alveoli that are ventilated but not perfused.
Exactly, very good. So wasted ventilation, you can also call it as wasted ventilation. So air is reaching up to the alveoli, but unfortunately, as I told you in the ARDS picture, microcirculation is blocked. So there is no capillary blood flow that is coming to pick up the oxygen and release the carbon dioxide. So that is also counted as dead space. So that is the physiological dead space. Alveoli which are ventilated but not perfused, they also contribute to the formation of dead space. So the anatomical dead space plus the alveolar dead space is ideally called as physiological dead space. Okay. So it is not only the anatomical dead space where just gases travel and to and fro, but also the alveoli which are ventilated but not perfused. Both of them combined together is called physiological dead space. So the physiological dead space is a combination of anatomical dead space plus alveolar dead space. Okay. Represents the volume of ventilated air that does not participate in gas exchange. Two types are there, anatomical and physiological. And physiological is nothing but anatomical plus alveolar. Okay? And this is about roughly 150 ml, 30% of normal tidal volume. And physiological or total dead space equal to anatomic plus alveolar dead space, where there is no perfusion but only ventilation is taking place. So in a healthy adult, alveolar dead space can be very negligible. Therefore, physiological dead space is always equal to anatomical dead space in a healthy individual. Whereas in pathological condition, as I told you in ARDS, then it can contribute to alveolar dead space will contribute more to the total physiological dead space. So an increase in the value of physiological dead space occurs in some lung disease states where diffusion membrane of alveoli does not function properly or where there is no perfusion properly happening. And the Bohr equation can be used to calculate the amount of dead space in the lung. That is a very important concept of that. And here Vd is equal to Vt multiplied by partial pressure of arterial carbon dioxide minus that same formula what I told you is used here. So this is the formula commonly asked in the examination or in ASCII, where how to calculate the dead space. You have to multiply the tidal volume with the PaCO2 minus expired carbon dioxide divided by arterial carbon dioxide. This formula you have to remember. And earlier it was alveolar carbon dioxide by the original Bohr equation, and Enghoff is the person who modified or changed the alveolar to arterial. Okay. How can you measure the anatomical dead space? Can you measure the exact volume? We roughly say it is about 150 ml or 30% of the total tidal volume. But is there any method or laboratory technique by which you can measure that? That is one of the theory questions that may be asked in the theory examination. So what is the technique you can use?
Nitrogen washout.
Nitrogen washout technique, very good. So any name for that?
Fowler's method.
Fowler's method, very good. And it's called Fowler's method. So patient is asked to inspire 100% oxygen. Because your normal air, what is the composition? Which is the majority gas?
Nitrogen.
Nitrogen. Okay. Almost 80% is nitrogen, 20% is only oxygen, and very, very minor form of carbon dioxide, carbon monoxide, helium, and all other gases are very minimal. So majority is nitrogen and oxygen. So you ask the patient to inhale 100% oxygen so that you fill the entire respiratory tract, but you cannot replace the residual volume and other things with that. So what happens when the patient exhales out? First the dead space gas will come, which will not have any nitrogen, isn't it? But later on, the latter part of expiration, what comes will be the nitrogen containing gas, which will be in the alveoli and which cannot be easily replaced completely, and you calculate that portion which is containing nitrogen, and the portion which comes out purely as 100% oxygen is the dead space gas. So that is how the Fowler's method, you inhale pure oxygen and exhale, pure gas comes out, then mixed gas comes out, lastly alveolar gas comes out. So based on that plotting, you can exactly measure and find out what is the anatomical dead space. So this Ward Fowler assembled an apparatus to measure the anatomical dead space and measure the exhaled nitrogen concentration following inspiration of a breath of 100% oxygen. Okay. Then roughly you can calculate it by body weight in pounds. So if you want to exactly say how much ml of dead space is there, you calculate your body weight into pounds instead of kilograms. How much pounds is 1 kilogram?
2.5.
2.2, exactly, very good. 2.2 is the pounds in equal to 1 kilogram. So if you are weighing roughly 70 kg person, 70 into 2.2 is 140 plus 14, 154. So exactly 154 ml will be your dead space. So that is how you can calculate the dead space. And so total dead space is anatomic plus alveolar. And if you are going to anesthetize the patient, then you have a mechanical dead space also. So the types of dead space are anatomical, alveolar, both combined called physiological, plus there is a mechanical dead space if patient is going to undergo any anesthesia or artificial ventilation, which we will see in the next slide. So what is apparatus dead space and how is it different from physiological dead space? Do you have a control over physiological dead space? Can you change your anatomy or the type of ventilation of the alveoli?
No, sir.
No, sir.
But apparatus dead space, do you have a control?
Yes, sir.
Yes, you can alter that. Okay. So apparatus dead space defined as the dead space resulting from the devices placed in between the endotracheal tube and the breathing circuit, and it is completely controlled by the clinician. Okay. So why apparatus dead space is more important in infants and neonates rather than adults? So dead space by definition we have seen is part of the gas that is not taking place in the gas exchange. So infants and neonates, why you should be very careful with the apparatus dead space? Do they have a large tidal volume?
No, sir. Smaller,
Their tidal volume is very, very limited. So if the apparatus dead space occupies more of their patient's tidal volume, then how much of gas exchange can take place? Very minimal. Okay, so that will infiltrate. So due to small tidal volume required by infants and neonates, it is easy to create excessive apparatus dead space, resulting in unintended hypercarbia or increased minute ventilation in an effort to keep the PCO2 normal. Okay, so that is the reason why IRTPs, which is commonly used, or Jackson-Breeze modification of IRTPs, was created mainly for this purpose by Sir Philip Ayre, who was the British anesthetist, was given the Sir title, the biggest reward or the honor by the British Queen. So it's called Sir Philip Ayre TPs. So apparatus dead space is important because of the small tidal volume of the infants and neonates. Now I am going to show you some connectors and their apparatus dead space volume, how much each one. Have you all seen this type of connectors here? What is A? Can anyone identify? which has this is a modification. Very good. It's a HME filter or a bacterial filter. This is a bacterial filter adapter. This is a HME filter. And what is this C? Any name for this? This is called an elbow connector, right angle elbow connector. And what is this catheter thing for?
ETCO2.
ETCO2 connection. Fantastic. Very good. And D and D, they both are same or different?
Same, sir.
Same. What is the difference?
The connected tubings are extended, sir.
So this is a collapsible connector. Okay, this is a collapsible connector. So you can expand it by stretching it out. So when you keep it in the collapsed position, the apparatus dead space is only 13 ml. If you expand it, it becomes 25 ml. Okay, so these are all the various connectors which can be avoided, and you can directly connect it to the ET tube. Then you can reduce this much of tidal volume, especially in neonates. So where does the apparatus dead space end in a particular circuit? That is a very important knowledge all of you should have, so that you can reduce the amount of dead space, apparatus dead space that patient is going to breathe from. Now the picture we are showing here, two circuits I am showing. One is Mapleson B circuit, another is the Bain circuit. Now in these two pictures, up to which area is the dead space?
Till the mask, sir.
Till the mask. Okay. Not at the expiratory level. So always remember, the apparatus dead space will end at the point where fresh gas flow is entering. Okay. Or if the presence of the expiratory valve. But here, even though expiratory valve is here, apparatus dead space will stop here because fresh gas flow is entering very close to the mask. Here also in Bain circuit, fresh gas flow is being delivered very close to the mask. So in both these circuits, the apparatus dead space, if I have to shadow it, it will be only up to this. Whereas in this also, what is this circuit? Any idea? I can give you a clue. This resembles an alphabet.
J modification.
T. It is the T piece. Okay, it is an older version of IST piece. When we had no plastic material available, this is a metal IST piece attached with the fresh gas flow. F is the fresh gas flow, P is the patient end, R is the reservoir. So you can see that IR constructed this circuit without a reservoir bag. So this is only the expiratory limb. And even though the expiratory limb is longer, the apparatus dead space will end because fresh gas flow is entering here. So only this portion is the dead space caused by the IST piece. Very, very minimal dead space. That is one of the advantages that I thought about. And this is another circuit which is used. Can you tell me or name this circuit? Fresh gas flow is entering here. Reservoir bag is here. This is fresh gas flow flowing here, and this is the expired air coming out through the expiratory valve. Which circuit is this? Very useful for spontaneous ventilation.
Mapleson A, sir.
Mapleson A or McGill circuit. Fantastic. That is because it has an expiratory valve close to the patient. So the apparatus dead space will end here. All the expired gases will go out into the atmosphere, and only fresh gas flow will be going into the patient. Patient will not be rebreathing the expired gases. Okay, that is the advantage of McGill's or Mapleson A circuit. for spontaneous respiration. So the 2 points that you have to remember is apparatus dead space will end where fresh gas flow entry is happening inside the circuit or where the expiratory valve is positioned. These are the 2 points which will determine the volume of apparatus dead space. Lesser the apparatus dead space, better the oxygenation and ventilation for the patient, especially if they are neonates or infants. This concept you have to have a very, very clearly in your mind so that you do not cause unnecessary dead space to the children when they are, if you are going to become a pediatric anesthetist, you have to keep this in mind. And what happens to patients in pulmonary hypertension? Is there any change in their dead space? The pulmonary circulation is affected as we saw in the COVID times or in ARDS patients. You get a wasted ventilation, alveolar ventilated, but circulation is not there. But if the patient simply has a pulmonary hypertension, the pulmonary pressures are high, will it affect the dead space? So with normal subjects, demonstrate at least 50% reduction in physiological dead space compared with their resting measurement. Patients with pulmonary hypertension typically fail to have any change in dead space during exercise especially. Okay? And what is the clinical significance of change in various conditions which can affect the dead space is lung disease. Emphysema destroys alveolar tissue, leads to increase in dead space volume. And ARDS, because of reduced circulation, it also causes increase in dead space. When VQ mismatch occurs, perfusion ventilation mismatch, that will also create additional dead space. And mechanical ventilation, you have to be careful with the tubing and the adapters or connectors that you use, which all can cause dead space because of the apparatus intervention. And if you use PEEP, excessive PEEP can over-distend alveoli, result in barotrauma, and also they can increase the dead space volume. Hypoxia will result in bronchoconstriction and vasoconstriction, that will also decrease the dead space volume. That will decrease the dead space. So the conditions which increase 1, 2, 3, 4, 5 conditions I have mentioned in red because they all increase the dead space. Whereas hypoxia decreases the dead space, even though it is going to cause ultimately damage to the patient. Dead space will decrease because both bronchoconstriction and vasoconstriction will happen. Anesthesia also increases the dead space because of bronchodilation of the anesthetic gases. So more volume will be accommodated in the conducting zones. That will also cause increase in dead space. And it is an integral part of volume capnography, which measures expired CO2 and dead space on breath-to-breath basis can be measured using volume capnography. What is the other type of capnography?
Time capnography.
Time capnography, fantastic, very good. So how do you differentiate between a picture of volume capnography and time capnography? Any idea? How pulmonary embolism can be detected using this also. So simple capnographic measurements. So exponential decrease in EtCO2 will cause this thing, and how the pulmonary occlusion causes increase in dead space is shown here. So high flow nasal oxygen augments the oxygenation by filling up the entire dead space. So another important concept that you have to understand how high nasal flow increases the oxygenation is when you use 10 liters, 15 liters of oxygen, what happens is the anatomical dead space is fully replaced by 100% oxygen, especially when you use 45 liters per minute for 500 milliseconds. That itself can completely replace all the air in the anatomical dead space. So whatever patient is inhaling, they will all be 100% oxygen, and that will improve the oxygenation very well compared to the low flow oxygen technique. Now comes the next important thing is about resistance. And what is resistance? Again, define resistance and what are the factors responsible for that. Any idea what is resistance? Simple English definite meaning. When you say somebody is resisting you, what do they do to you? You are entering a room. I am resisting you. What does it? I am blocking you.
Stopping,
preventing you from entering, isn't it? I am impeding your entrance. So resistance simply means that only. Okay. So the pressure difference between the mouth and the alveoli divided by the flow. That is how you calculate the resistance. So for example, if you are taking 500 ml at the mouth and you alveoli gets only about 150 ml, what happens to the rest of the 350 ml? It is all been blocked in the respiratory zone itself. So that is what is called the resistance. So factors which affect the resistance are air flow velocity, the diameter of the passage, already what is present in the lung volume, whether airflow is laminar or turbulent. These are the two types of airflow that normally. Which one is preferable? To have a laminar flow or a turbulent flow?
Laminar.
Laminar flow, because that will cause a easy smooth sailing flow. Okay. So these four factors are the ones which are going to affect your passage of your gases through the respiratory tract, and that hindrance caused by that is called the resistance, and that is measured or calculated by the pressure difference between the mouth and alveoli divided by the flow volume of flow of the gas. So what is the pattern of airflow? It is present normal in the anatomical lung, and is airway resistance constant throughout the lung field or different?
In the conducting zones, it's more turbulent, and in the smaller, it becomes more laminar level of the alveoli.
The alveoli, it becomes laminar. Wherever there is a branching, it will become turbulent. Okay, that is the reason why they become turbulent, because of the branchings. Whereas if you have a straight course, then it will be more laminar. And which formula is useful in calculating whether it is going to be a laminar flow or a turbulent flow?
Hagen-Poiseuille's equation.
Hagen-Poiseuille.
Very good. So this is the anatomical lung airflow is primarily laminar, which allows to utilize the Poiseuille's law. And all of you may be remembering this. This is also another common thing asked in the ASCII or in your short note questions. So the flow rate of a gas is pi multiplied by the pressure, by the radius, viscosity and length are all taken into account. 4 times the radius divided by 8 times the viscosity and length. So airway resistance is not constant throughout the lung field, it varies, and resistance is maximum in the tracheobronchial. Where is the maximum resistance in tracheobronchial tree, and where is it low, and what is the reason for it being low there? Imagine the picture that we saw in the last class, your tracheobronchial tree starting at the trachea, dividing into right main bronchus, left main bronchus, then upper lobe bronchus, middle lobe bronchus, lower lobe bronchus in the right side, upper and lower in the left, and then segmental bronchi. Where do you think will be the greatest in the bronchi of intermediate size, in between the 4th and 8th bifurcations? And the resistance is low at the periphery of the lungs because of the large cross-sectional area. Okay? And which pressure will increase if airway resistance is increased in the ventilated patient, and how to correct? which pressure means it is the peak inspiratory pressure or the plateau pressure. These are the two pressures which you normally see in the ventilator graphics. So if the patient is mechanically ventilated, we always look at the ventilator graphics to see what is the maximum peak inspiratory pressure that is reached when the patient is inhaling or the inspiratory function is going on, and then how much of stabilization it happens. That is called the plateau pressure. So in ventilated patient, only the peak inspiratory pressure will increase, and there will be no increase in the plateau pressure when airway resistance increases. And the problem can be remedied depending upon the cause, which include retained secretions which can remove, or bronchospasm where you have to administer bronchodilators, or water in the ventilator circuit which you have to drain. When both peak inspiratory pressure and the plateau pressure increase or decrease, it is a compliance of lung issue. Okay? So it is the airway problem resistance only if the peak pressure, inspiratory pressure alone is increasing. But if there is a change along with the peak inspiratory pressure with the plateau pressure, then the alveolar compliance is altered. So that is what you have to remember by understanding this. Then there is a terminology which is used called venous admixture and shunt. Are they both same or different? That is the first thing that we have to understand. What is venous admixture and what is shunt? This is with regard to the circulation and ventilation that is taking place in the lung.
Venous admixture refers to some of the veins that drain directly into the left atrium, sir.
Can it be called as shunt? That means they are 100% deoxygenated blood, isn't it?
Yes, sir.
If the veins directly drain into right atrium or left ventricle, that means they do not expose themselves to any air to take up any oxygen. So they are purely venous blood coming and draining directly into the pool of oxygenated blood. So that should be called as shunt. Whereas a venous admixture is partially ventilated alveoli which do not have adequate oxygen to replace the fulfill the venous blood. That is called venous admixture. Okay? In venous admixture, the blood flows through partially ventilated alveoli where it is not able to get 100% oxygenated like the other well ventilated areas. So it is a venous blood with extra amount of oxygen but not fully oxygenated. Whereas shunt is a condition where venous blood without getting exposed to oxygen drains fully back into the pool of oxygenated blood to reduce the total oxygenation in the body. That is called the shunt. Okay? Shunt is the blood which enters systemic arterial circulation without participation in gas exchange. Whereas venous admixture is the amount of mixed venous blood which would have to be added to ideal pulmonary end capillary blood to explain observed difference between the pulmonary end capillary arterial oxygenation and arterial oxygenation. So this is the venous admixture. In simple terms, remember it goes through partially ventilated alveoli, whereas shunt is purely venous blood without exposure to oxygen. And shunt fraction is calculated by using the ratio of venous admixture to total cardiac output. And shunt equation is another thing that can be asked. It's also called any other name for that. It's called the Berg-Gren equation. And it is used to calculate 2S is the 2SPT is the shunt fraction. 2S means the quantity of shunt, total flow of blood flow. It can be calculated using this formula CCO2, which is pulmonary end capillary oxygen content, which is almost equal to alveolar oxygen content, and CaO2, arterial oxygen content, CvO2 mixed venous oxygen content. So by using this formula, we can find out true intrapulmonary shunt, another condition called VQ scatter, and these three veins, Tebesian veins, bronchial vein, and intracardiac shunts, these are the real shunts where venous blood as it is comes and mixes with the oxygenated blood. So the sources of true shunt are Tebesian veins, bronchial veins, and intracardiac right to left shunts. For example, in tetralogy of Fallot, where there is a severe pulmonary obstruction and there is a VSD, overriding of aorta, then the right ventricular blood, without going to the pulmonary circulation, mixes with the left ventricular blood. So that is called the right to left shunt, which are all true shunts. Whereas other VQ scatter or other areas where some amount of oxygenation would have been happened. And how is shunt classified? You can classify as physiological shunt, which is again anatomical shunt due to bronchial and Tebesian veins, functional shunt, which is a VQ mismatch or scatter. Pathological conditions are the intracardiac shunt, pulmonary AV malformation, or intrapulmonary shunt, which is a true shunt. All these structural abnormalities. So true shunt, blood passing through diseased pneumonic lung with no oxygenation at all. Ventilation is zero and only blood flow is happening. That is called the true shunt. So the blood goes as a venous blood to the common pool. So this blood will exchange no gas. And the other term VQ scatter, which is used, is a lung region where VQ ratio is less than 1, but will have sufficient gas exchange, will return pulmonary venous blood which is incompletely oxygenated. So venous scatter or VQ mismatch is a terminology to be used where alveoli are partially ventilated and the blood does not get fully oxygenated. It is partially or incompletely oxygenated. Then it is called VQ scatter or VQ mismatch. So as the name suggests, oxygen content of such blood will be available in a wide range from blood which is closely resembles mixed venous blood to blood which is only slightly deoxygenated. So that depends on the amount of ventilation that is happening in the alveoli through which the capillary blood is going. So remember these two terminologies. A true shunt, it is a zero oxygenated blood. VQ mismatch or scatter, partially oxygenated blood. If you remember that much, it is enough to remember this. Now we are showing here pictures of what is being done here. You can see there is a healthy alveolus. To remember the earlier concept. So alveoli are getting properly ventilated. Capillaries also have a good blood flow. So here they both are matched, ideal couple made for each other. Ventilation, perfusion are matched. The second category is alveoli are not ventilated, but capillary blood flow is going. Okay, so this is the venous blood coming as it is. So this is called the shunt. And here third category, alveoli are to some extent ventilated or partially ventilated or fully ventilated, and collapsed capillaries happen. This is a dead space. So alveoli ventilated, but blood flow is not there. So this becomes a dead space which we saw in, as we saw in ARDS and other conditions. The same thing in other pictorial description. So what will be the VQ mismatch in these things? So if it is a true shunt, it should be zero because there is no oxygenation at all. And other conditions, it may be partially doing that. So what will be the partial pressure in various conditions? This is also shown here, difference between shunt and VQ mismatch in what is happening by understanding the. So three types of changes. One is normal, another is shunt, third is the dead space. And this is the shunt fraction, which we already seen, how to identify the true fraction. You can ask the patient to inhale 100% oxygen. You increase the FiO2 to 100%. A partial shunt or venous admixture will improve, whereas a true shunt will not improve. That is why in cases of tetralogy of Fallot, even if you give 100% oxygen, the saturation does not come up because the blood is not getting oxygenated because of the pure mixing of the venous blood with the normal oxygenated blood. So remember, those two examples are clinical conditions which will help you to remember what is a true shunt. So true shunt is one, the venous blood is never exposed to oxygen and becomes or joins the oxygenated blood as it is. Whereas venous admixture is where partially oxygenated and just decreases the shunt, the mixing or the saturation. So that can be improved. Venous admixture can be improved by oxygen therapy, whereas true shunt cannot be improved by oxygen therapy. That is the basic thing that you have to understand. Now comes the next another gray area, alveolar equation, and what is it used for? Any idea what is the alveolar equation? This is another question that is repeatedly asked in the theory exams. Right. Alveolar gas equation is used to calculate the alveolar oxygen partial pressure. Okay. So we all know that we are breathing only room air most of the time, and room air, how much of oxygen is there?
21%.
21% roughly. So we are breathing 21% or 0.21 percentage, 21 liters, 21% or 0.121%, whichever way you want to say, is the air, oxygen that we get from the atmospheric air. What is the normal barometric pressure?
760 millimeters of mercury.
760 millimeters. How much of water vapor is there in our atmospheric air?
47.
What is the pressure caused by that water vapor?
48 millimeters of mercury.
So 760, you have to subtract the pressure caused by the water vapor. Then you can multiply it with arterial carbon dioxide divided by minus this, the arterial carbon dioxide divided by the respiratory quotient. So if you remember this formula, this will give you what is the partial pressure of oxygen. Why do we have to know what is the partial pressure of oxygen? Why they are giving so much importance to such a confusing or the so-called not looking so important factor? Is it important or not?
Important, sir.
Hey. With regard to the properties of a gas, all of you would have studied in your school days. The transfer of gas, how does it take place?
Higher concentration to lower concentration. Diffusion.
Diffusion.
Pressure gradient. That is the terminology that will be ideal to suit to describe that. Okay. It always flows from an area of higher concentration or higher pressure to an area of lower concentration and lower pressure. Okay. So if only your alveolar oxygen pressure is higher than the entire pressure of oxygen inside our body, then only oxygen from the air can enter our body. If our body has a higher oxygen pressure, can we take the oxygen from the air? Impossible. Okay. So that is the reason why this concept of alveolar oxygen pressure. Supposing you go to Ooty or Kodaikanal or Himalayas, what will happen to the oxygen pressure that you are taking in? Will it be same or not? Reduced?
Reduced.
Reduced because of the lower barometric atmospheric pressure. Okay. That is why people who are not used to the high altitude, or people with lung diseases, or people who go for parikrama to Rishikesh and Kedarnath and Badrinath, they are all made to see whether they can withstand that lower ambient pressure of oxygen there. Okay, so we will be seeing what drug they will be usually given before they travel and trek and go to the higher altitudes. Okay, so in the high altitude, the oxygen partial pressure will be low. Then you find it difficult unless you give a supplementary oxygen at a higher pressure. People cannot sometimes survive unless they are good, very healthy persons. They cannot survive. So that is the reason we have to know about the alveolar partial pressure of oxygen. Okay, and that is calculated using the formula, the FiO2 multiplied by the atmospheric pressure minus water vapor, from which you subtract the arterial carbon dioxide divided by respiratory quotient. And so here you can see the water vapor pressure is 47, atmospheric pressure is 760. So the net pressure will be 713, and the carbon dioxide level divided by respiratory quotient, usually considered to be, respiratory quotient is 0.85. So at the sea level, this is the value that you will get, roughly about 99.7 millimeters of mercury, or roughly say 100. And even this 100 sometimes may be little lower, but roughly you require this much of pressure in the alveoli for the oxygen. That is why I told you, when the venous capillary blood comes with a pressure of 40, there is a good gradient, 100 on the alveolar side and 40 on the venous side. It is easily pass through that and come out. Similarly, carbon dioxide has a higher pressure in the venous blood of the capillaries coming in the pulmonary, alveolar pulmonary capillaries, and the carbon dioxide pressure in the alveolar air is very, very negligible. So that is also able to cross and go. So that is the reason why this question is asked in the exam. And what is the alveolar arterial gradient that is happening? So as it is, venous gradient will be very low, but once it gets oxygenated, the arterial blood also has a slightly lower value compared to the alveolar value. So this gradient is very, very important to maintain the transfer of gases from the alveoli into the venous blood, which will become oxygenated, and the arterial blood has to be carry the oxygen to the various parts of the body. So what factors influence this alveolar arterial oxygen gradient? The normal gradient depends on the age, body position, nutritional status. A normal AA gradient for a young adult non-smoker breathing is between 5 to 10 millimeters of mercury. And normally the AA gradient increases with age. For every decade, it has to decrease by 1 millimeter of mercury. So that is why older people always have a slightly lower saturation, which is acceptable because of the change that happens in all the tissues that are getting older. Now comes the next concept of positive end expiratory pressure, and how does it happen? Do we have a positive end expiratory pressure in our body in a normal respiration?
Yes, sir.
Yes, sir.
Yes. So what is the purpose of that?
To prevent complete collapse of the alveoli.
Complete collapse. Very good. It's a positive pressure that will remain in the airway during respiratory cycle at the end of exhalation, and that is greater than the atmospheric pressure in the mechanically ventilated person. Okay, so these are the two things. In a positive, in a normally spontaneously breathing patient, it happens at the end of exhalation, and in a mechanically ventilated patient, we normally include the positive pressure from the machine so that we can keep the therapeutic parameter is set in the ventilator, and it's a if you do not adjust it correctly, that can be harmful, because normally you are supposed to exhale the gases and then restart your inspiration. But if your positive pressure at the end of exhalation is too much, it will not allow the exhalation of the gases, and they will be quietly going on accumulating in the alveoli. And one particular stage, the alveoli cannot bear any more volume, and that can suddenly rupture and produce a barotrauma. Okay, so that is the complication that can happen because of this particular setting of PEEP in the ventilator. But how does PEEP helps in the respiration? What gas laws are applicable to this? As I told you again, physics will come in every stage of the mechanics that we learn. So what gas law is applied, and PEEP is used to improve the oxygenation of the patients. This is not the common three gas laws. It is neither Boyle's law nor Charles' law or Gay-Lussac's law. So can you think of any other gas law?
Fick's law of diffusion.
Fick's law. Fick's law is it a gas
Law.
law? Huh? Did you watch a South African New Zealand match yesterday? Do you know one of the fast bowlers of New Zealand? It's Henry's law. Okay, extrinsic PEEP can be used to increase oxygenation. Henry's law is the solubility of a gas in a liquid is directly proportional to the pressure. Where else this Henry's law is applicable?
To calculate the oxygen content in blood.
Oh,
Dissolved oxygen we calculate by using Henry's law.
no. Henry's law, where else in practical application? How do you treat carbon monoxide poisoning?
Hyperbaric oxygen.
So the hyperbaric oxygen also works on the principle of Henry's law. So the solubility of a gas in a liquid is directly proportionate to the pressure of the gas on the surface of the solution. So this increases the solubility of oxygen and ability to cross alveolar capillary membrane and increase the oxygen content in the blood. That is how PEEP works. So extrinsic PEEP can be used to improve ventilation perfusion mismatches. The application of positive pressure inside the airway can keep the airway splintered or open without collapsing, decreases atelectasis, and thereby improves the ventilation, and in turn decreases the VQ mismatch. So extrinsic PEEP significantly decreases the work of breathing also. Okay, so these are the few points that you have to remember. If the examiner asks how the PEEP works to improve the oxygenation, it is by the application of Henry's law, where the partial pressure determines the solubility of oxygen, and also it improves the VQ mismatch, and it decreases the work of breathing. These are the three important points, and also decreases atelectasis by keeping the alveoli open. Okay, so 4 points you have to remember. What are the complications caused by PEEP?
Hypotension.
Hypotension, very good. Why hypotension?
Venous return is impaired, sir.
Venous return, because the negative pressure which is required for venous return to the right side of the heart is abolished completely by the positive pressure created inside the thorax. Okay, so normal respiratory physiology works as a negative pressure system. When the diaphragm pushes down during inspiration, negative pressure in the pleural cavity is generated, and which sucks the air into the lungs. And the same negative pressure also decreases the right atrial pressure and generates a sucking effect on the IVC, which increases the venous return. So lungs are also inflated, right atrium is also filled by the negative pressure. So by application of extrinsic PEEP, what do? We completely alter this normal physiology of negative pressure inside the thorax. We completely convert it into a positive pressure all the time. So this will definitely increase the RA pressure, which will decrease the venous return, decreasing a preload. So less blood in RV means less blood reaching LV, which is causing to cause the decreasing cardiac output, and this is the main reason for the PEEP to cause the hypotension. So decreased preload means the heart works at a less efficient point in the Frank stalling curve, generating less effective work and causing a drop in mean arterial pressure. So this is the main important cardiovascular effect of the positive end expiratory pressure. For this, the body should adjust with an increasing in systemic vascular resistance. And patients may not be able to increase their SVR if they have already a distributive shock like sepsis or neurogenic shock or anaphylactic shock, and they will have a very severe decrease in cardiac output, which will be sometimes quite causing morbidity and mortality. So the effect of RA pressure and venous return may be beneficial in patients with cardiogenic pulmonary edema. So the only cardiac condition where PEEP may be effective or useful is only in cardiogenic pulmonary edema, but not in other conditions. So these are the things. And how with cardiogenic pulmonary edema, it helps the decreasing the venous return decreases the preload because the heart is already struggling to pump the load. So you decrease the venous return. So the decreased preload will place the LV at a more efficient workload, possibly increasing the cardiac contractility and thereby improve the LV function. And decreased venous return means less blood pumped into the RV and less blood into the pulmonary circulation also. And so more water cannot go into the lung. So in both ways, it helps improves the left ventricular ejection, at the same time reduces the pulmonary flow from which only the fluid has to seep in into the alveoli. So in both these ways, in cardiogenic pulmonary edema alone, PEEP will be useful. Now, can PEEP be applied to patients who suffered a stroke or a subarachnoid hemorrhage?
No, sir. No.
Extensive PEEP. You have seen all the effects on the cardiovascular cardiac output and MAP. Okay, just consider this effect. So cerebral perfusion depends on the mean arterial pressure, isn't it? So if you have to maintain a good cerebral perfusion pressure by maintaining a good mean arterial pressure, then only patients with cerebral oxygenation will be maintained. So patient with disturbed cerebral vessel autoregulation, a decrease in MAP caused by PEEP will definitely affect the cerebral perfusion pressure and it will worsen the oxygenation of the brain. So in patients who have suffered a cerebrovascular accident, you should not use PEEP. That is the moral that you have to understand. What other adverse effects is caused by PEEP? This is the cardiovascular effect which we have seen.
Barotrauma.
What about barotrauma? Very, very good. So other adverse effects of barotrauma, especially if the lungs are non-compliant and we keep on increasing the plateau pressure, then it will interfere with not only the hemodynamic measurement, but also it will affect the right heart function also. And what basic principles apply to all modes of ventilation where PEEP is used? So what are the precautions or the steps you have to follow if you are planning to use PEEP to improve the oxygenation in a mechanically ventilated patient? That is the correct wording of the question. All seniors who are about to appear for exam, all of you would have seen in your, the 2 or 3 years of experience in ICU, when your assistant tells keep the PEEP without telling you how much and what is the condition of the patient. What are all the precautions you will follow to
I will
apply
look
the
at
PEEP?
the BP before looking keeping the PEEP and
Fantastic, very
set
good.
as
So
low if it is
hemodynamic
tolerating
stability
high.
to be assessed. Fantastic, very good. Then
Keep it as low, and if it's tolerating way, slowly increase up.
fantastic, fantastic. Start low and increase as tolerated to set the patient comfort and desired oxygenation. Constantly check plateau pressure to prevent paratrauma. As a general rule, keep patient pressure below 30 centimeters and follow MAP as you are dialing up or down. Okay, very important. These are the, so start with a low PEEP, say 5 centimeters, then increase it to 7, 8, 10, 15. Maximum you can go up to even 30, but the plateau pressure should be kept below 30 centimeters of water. And keep a watch on the mean arterial pressure. Even though you are not worried about the systolic or diastolic, always keep a watch on the mean arterial pressure. And when extubating a patient with cardiogenic pulmonary edema who has received extrinsic PEEP to control the edema, consider the effects on the venous return, as the sudden removal of PEEP may precipitate a new pulmonary edema and may warrant a re-intubation. Okay? So slowly wean from the PEEP. Do not suddenly decrease and extubate a patient who has been treated with PEEP for cardiogenic pulmonary edema. Okay, that is a very important precaution. And which protocol is used to guide application of PEEP? Any particular protocol? It's called ARDS-NET protocol. Provide clear guidance on how to titrate extrinsic PEEP and FiO2. Okay? So that is the things about PEEP that you have to remember. Then there is another category called auto PEEP. What we have been talking as so far is PEEP applied by us through mechanical ventilation, which is called extrinsic PEEP. But patients can develop an intrinsic PEEP or auto PEEP. And which conditions cause that and what are its effects?
COPD.
Complication, intrinsic or auto PEEP can also be a complication of mechanically ventilated patient. And usually passive exhalation will permit complete emptying of the air in the lungs, and lungs become the lung pressure should become equal to atmospheric pressure at the end of exhalation. But cases with lungs may not completely deflate. They may have air trapped inside the lung at the end of exhalation and generate a positive pressure that remains in the lung. That is the mechanism how the auto PEEP comes there. So this PEEP, which is due to the inadequate exhalation of the alveolar air, is the reason for the auto or intrinsic PEEP. And this process repeatedly happens. It goes to air trapping becomes more and more, and intrathoracic pressure increases pathologically, and the RA pressure will automatically compress, decrease the venous return, causing hypotension and increasing the plateau pressure, also causing barotrauma. Okay, so these are the ill effects of auto PEEP, and this will also increase the work of breathing of the patient. So when the inadequate exhalation happens, the retention of air and distension, because alveoli are to be optimally expanded. They should neither stretch too much nor collapse too much. So if they keep on expanding, stretch too much, then it requires more power to inhale the next breath. So that is what is called the increasing the work of breathing, and that will cause increasing oxygen consumption. This will result in more carbon dioxide production. So over a period of time, patient will go in for both accumulation of CO2 and inadequate oxygenation, which is called what type of respiratory failure? Decreased oxygen, increased carbon dioxide. Type 2 respiratory failure. Fantastic. Type 1 is only hypoxia. Normal carbon dioxide with hypoxia is type 1 respiratory failure. Both hypoxia and hypercarbia is type 2 respiratory failure. Okay. So what factors lead to PEEP? Airway inflammation or mucus plug generate the dynamic airflow obstruction. The other thing is high lung compliance as in COPD. And the third is high tidal volume ventilation. These are all the things which can lead to, that is why nowadays we go in for low tidal volume or small tidal volume ventilation or lung protective ventilation as we call it as. Okay. Now high respiratory rate also decreases the exhalation time, and slow inspiratory flow generating high respiratory time. All these things are the factors which cause autopnea. Then when will you suspect autopnea? Supposing you have ventilatory graphics available in the mechanically ventilated patient. What is the thing that will tell you that patient is developing an autopnea?
The scalars will never approach it will never approach, so it will keep increasing, sir.
Baseline, okay.
Baseline
So it
number.
will expiratory time will not, the curve of the graphics fails to go back to 0. That is the sign of air is being trapped. So you can see this picture. This is the inspiratory phase, the green thing. Then the expiration comes out. The dotted line, you can see expiration ends in the baseline. And then you have the next inspiration starting. On the contrary, the expiration which is not touching the baseline, it starts immediately the next inspiration. That indicates there is a air trapping occurring, and that is the way to detect that patient is going in for autopnea. So increasing PA2 pressure also will happen on the ventilator, and active exhalation of the patient seen by the use of accessory muscles of respiration during, as I told you, work of breathing will increase, and patient may have a drop in blood pressure, and long expiratory times will have. So how do you treat this autopnea? So this much of bad effects are there in the cause of development of autopnea. And over a period of time, it may lead to barotrauma also. So how do you treat autopnea?
Increase the output ratio, sir.
Huh?
Increase the exhalation time.
Increase the expiratory time. Okay, very good. IE ratio can be altered. So in the most extreme cases, when the patient is in respiratory distress and shock, simply disconnect the patient from the ventilator and allow enough time for exhalation before manually bagging the patient. Is a quick life-saving measure. This is for extreme cases. But in enough time for exhalation, assuring enough time for exhalation is the most important principle for treating or preventing autopnea. So IE ratio should be altered to 1:3 or 1:5. 5 times the time allowed for inspiration should be there. So increasing the inspiratory rate from 60 to 100 liters per minute will assure fast delivery of air inspiration, lending more time for exhalation also. And decrease the tidal volume, decrease respiratory demand by decreasing the CO2 also. So some amount of hyperventilation also will be useful in treating the autopnea. This is another graphical representation how to check for that intrinsic peak. By putting the patient on expiratory hold, you can see the peak is increasing, and this is another way to find out the respiratory phase suddenly starting out with the inspirator without touching the baseline. Okay? So this is how the classical ventilator graphics will look like. I thought I will hold the picture. Right now, after this, you now go on to two important effects. One is Haldane effect, another is the Bohr effect. What are these two effects important for? Now we have come from the travel of air from the atmosphere through the respiratory passage up to the alveoli, and oxygen has to be taken in and delivered to the tissues, where it will be used for aerobic metabolism for production of ATP, which will result in production of carbon dioxide, which has got to be carried again back to the lung for elimination from the body through expiration. So this is the travel of your gases in the body. So in this process, where do these effects come and play a role? Haldane effect and Bohr effect. Because this is a basic physiology, all of you would have studied.
Bohr effect takes place at the tissue and for delivering oxygen from hemoglobin, sir.
Haldane for carbon dioxide.
So Haldane effect describes how oxygen concentrations determine hemoglobin affinity for carbon dioxide, and Bohr effect is the one which describes how carbon dioxide and hydrogen ion affect the hemoglobin's affinity for oxygen. Okay, so this is simply, you can remember that at the tissue level, the blood has to give up the oxygen that it has carried all the way up to the capillaries, so that mitochondria will get enough oxygen for aerobic metabolism, oxygen transport, and the chain that produces the ATP, mitochondrial respiration, has to take place. And there the Bohr effect is very, very important, because when it comes to that level, the blood has got more hydrogen ions and it has to release the oxygen. As you know, the oxygen dissociation curve, which we read about, which is given here, it will be not, it will have to shift to the right. I always tell that oxygen dissociation curve, shift to the right is right for tissues, shift to the left is wrong for tissues. So if you remember that way, ODC curve, oxygen dissociation curve, shifting to the right will be good for the tissues, so that oxygen will be given up from the blood and it will reach the mitochondria. Whereas when it comes to the question of lung, you have to give up the carbon dioxide and take in oxygen. Okay? So there the affinity for carbon dioxide has to be reduced so that it will be given up. At the level of tissues, the affinity of the blood for oxygen to be reduced so that oxygen will be delivered to the tissues. So that is the two important things. So this is also called Bohr-Haldane effect, where at the lungs, oxygen has to come into the body and the carbon dioxide and of course some amount of hydrogen ion will also be given out. Whereas in the tissues, the oxygen has to go to the tissues and carbon dioxide and the hydrogen has to enter the blood to go to the lungs. So this is the two effects called Bohr and Haldane effect, and they are combined together called as HALI, where heterotropic allosteric ligand interactions produce the sum effect of Bohr and Haldane effect. So if these two effects take place normally, then only your oxygenation and CO2 elimination will be all right. If there is any interference in either Bohr or Haldane, Bohr will cause more tissue hypoxia, which will cause more acidosis, lactate formation, anaerobic metabolism, and interference with Haldane effect will result in retention of CO2, hypercarbia, and respiratory acidosis. So metabolic acidosis will be caused by Bohr effect. Respiratory acidosis will be caused by Haldane effect. So only when they both function normally, you will have a normal pH maintained by adequate oxygen delivery to the tissues and proper elimination of CO2. So that is the ultimate reason why you have to know about these two effects. Now you are showing what is being shown here.
ODC curves.
ODC curve, very good. So the commonly this is also another asked question. So you can see the central line is the normal ODC curve, and as I told you, shift to the right. That means oxygen is given up at a lesser partial pressure. So conditions which cause shift to the right are increase in CO2 or hydrogen ion, temperature, increase in 2,3 dpg. These three things, if they increase, they will all cause more release of oxygen. That is PCO2 increase, acidosis, hyperpyrexia, and DP3, 2 DP3, DPG increase, and a decrease in pH or self-hemoglobin, HPSS, all these things will cause also shift to the right. So in shift to the right, oxygen affinity of the blood is reduced, oxygen unloading or delivery to the tissues will be increased. That is why I told you shift to the right is right for the tissues. Whereas when it gets shifted to the left, the conditions which are causing the shift to the right, opposite things will happen. You have hypocarbia, you have alkalosis, you have hypothermia, you have increased decreased 2,3-DPG, alkalosis, phosphate, methemoglobin, carboxyhemoglobin, fetal hemoglobin. All these things cause the shift to the left, in which condition blood wants to retain the oxygen. It doesn't want to give up it to the tissues. So oxygen unloading is affected. And this P50, this is another question that commonly examiners ask you, what is this P50? And what is its importance?
The partial pressure of oxygen at which it is 50% saturated with hemoglobin.
50% oxygen, okay. So this is the PO2 at the 27. This is the value that they may ask you. 27 millimeters of mercury. If the arterial PO2 pressure is 27 millimeters of mercury, at that time you expect the saturation to be about 50. Okay, this is the normal value, and accordingly it will get shifted when the ODC curve gets shifted also. Okay, it will have even at a lesser percent it will be saturated and it will be able to deliver. So that we can understand by this P50 value. So this is the ODC curve. What is this curve?
Carbon dioxide dissociation.
Carbon dioxide dissociation curve. So compared to the ODC curve, which is called the sigmoid shaped or S-shaped curve, carbon dioxide curve is almost a linear curve, moves in a straight, almost exponential way. It goes straight like this. So this is the carbon dioxide transport curve. So what are all the various levels at the arterial level and venous level? What is the level of carbon dioxide? You can find it. The gap is very, very small here. Okay. So the concentration in ml plus PCO2 measurement, the same thing plotted like your ODC, but in arterial blood it is about 40 millimeters of mercury. In venous blood it is about 45 millimeters of mercury. So very, very small gap between the two, and it is mainly carried in what forms that we will be seeing in the next slide. So what is this?
West zones of lungs.
West zones of lung. Very good. So what is the importance of this west zones of lung?
To look at the ventilation and perfusion.
It depicts the various levels of ventilation and perfusion at various segments of the heart, I mean lung. So it is not constant, as I said in the earlier slide, it differs. So the upper zone, middle zone and lower zone, what happens? Three important parameters are to be taken into. What are the three important pressures that you have to take into consideration? See, the capillary blood is coming like that. Even though they say artery, it is the pulmonary arterial blood which is coming here, which has to be carried as an oxygenated blood back to the left atrium. So this is coming from the right atrium, has to go to the left atrium. And this is the alveolar pressure. So here in the zone 1, which is usually the apical zone, you have the alveolar pressure which is more than the capillary pressure. Okay? So the capillaries are made very small here to understand. So alveolar pressure is always more than the capillary pressure. Whereas in zone 2, where there is a capillary dilatation is slightly there. So venous side you have the capillary pressure is higher than the alveolar pressure. And in zone 3, you have both the alveolar and capillary pressure are almost as per the picture it looks normal. Then interstitial pressure produced by the alveoli. So in the west zone there is a small confusion. Some books will say only 3 zones, 1, 2, 3, and some books will say there is a zone 4. So when you talk about zone 4, it is the interstitial pressure of the alveoli between the alveoli and the capillary is also taken into account. Whereas the original zones, 3 zones of west, they talk about the pulmonary capillary, alveolar arterial side, venous side, and the alveolar pressure. These 3 only will be compared. And in the upper zone, it is the alveolar pressure which is higher than both the arterial pressure and the venous pressure. In zone 2, the venous arterial pressure will be more than the alveolar pressure, but lesser than the capillary pressure, venous pressure. And in zone 3, actually, the arterial pressure will be more than the capillary pressure and alveolar pressure will be the lowest. So this is how the 3 zones are there, which tell you about what is the important, why we should know about is to understand the VQ matching, that is ventilation perfusion matching, how it is taking place is defined by this west zones of the lung. So that will produce this. What is this picture? This is mainly, of course, not connected to each other. This is I thought of suddenly putting all these things for auspices for so that you can shift your thoughts from one concept to another. Any idea?
Flow volume loop.
Flow volume loop. Yes, very good. So what is this? You have the lung volume, you have the alveolar pulmonary pressure, inspiration, expiration, pressure and volume. Okay, this is pressure volume changes. Okay, here it is flow volume loop. Here it is pressure volume changes in the lung. And what is this? You have an inspiratory curve going like this. This is expiratory.
Loops.
Hysteresis, fantastic. Work of breathing or hysteresis. Okay. So the inspiratory path is not the same as expiratory path. So that is the word or meaning for hysteresis. Hysteresis means the inspiratory path is not the same as expiratory path. So that is, supposing you say inspiration goes like this, expiration comes back like this, it's a straight line. Then this is not hysteresis. So the inspiratory and expiratory paths differing from each other is called the hysteresis, which depicts the work of breathing. Okay, so these are all some of the things. Next comes the importance of oxygen cascade. How and why oxygen cascade is important. All of you know what is a cascade, isn't it?
Sir.
A stepwise fall is a cascade. All of you, when you go to Kodaikanal, first thing you come across is silver cascade at the entry of the city of Kodaikanal. All of you stop there and find water flowing from the top of a small hillock in various steps. Okay, so that is called the oxygen cascade. What is the importance? Why you should know about oxygen cascade? Again, I have been telling alveolar pressure of oxygen should be the highest, then arterial oxygen tension, then the various stages oxygen tension goes on getting decreased, and ultimately when the oxygen comes to deliver at the mitochondrial level, what is the pressure? What is posture point?
3 to
Below
4
which
millimeters
anaerobic
of
respiration
That
takes
is the
place.
value. The lowest pressure required for oxygen to travel and go to the mitochondria. It's called the posture point. So that is about 2 to 3 millimeters of mercury. So from almost 100 millimeters of mercury, When it ultimately gets delivered to the mitochondria within the cell, the pressure drops to almost 2 to 3 millimeters of mercury. This stepwise reduction in the oxygen partial pressure is what is called oxygen cascade. Okay. So in respiratory physiology, oxygen cascade describes the flow of oxygen in a human from air to mitochondria, and oxygen flows from areas of higher partial pressure to the lower partial pressure. So this picture tells you at the alveolar level, at the lung level, in the atmosphere, the partial pressure is 159. But when it comes to alveoli, we have seen the alveolar equation. Please recall and recollect how we calculated FiO2 multiplied by barometric pressure minus the water vapor pressure minus the PaCO2 divided by respiratory quotient. Then we arrive at a value of almost 100 millimeters of mercury at the alveoli. So that is the alveolar partial pressure. So from atmosphere of 159, it comes to alveoli where it is about 99 to 100%, 100 millimeters rather. And then at the end capillary, it is still almost, end capillary blood, arterial blood, it comes to 92. And then as it diffuses at the tissue level, it goes to 33. And at the mitochondrial level, it comes to 5 millimeters of mercury. So the way it travels, it is all by diffusion. And venous admixture, it gets reduced. And finally, you will end up with a partial pressure of 5 millimeters of mercury, which has to be maintained for mitochondrial oxygenation. So if any problem occurs in between these stages, then tissue oxygenation will be suffering. That is the ultimate reason why we have to know about oxygen cascade. So this picture tells you how the whole thing happened. Now another important thing is oxygen flux. Even though they are, I'm just mentioning it as what exactly you understand by the terminology of flux. So after oxygen cascade, you must know the oxygen flux. Flux is a meaning continuous moving or on passing by. So when we saw in the last slide oxygen cascade, oxygen is not stagnant anywhere. It is continuously flowing from the atmosphere to the alveoli, alveoli to the blood to the various levels, get mixed with other things, and ultimately comes to the tissues. So this flux means is a continuous moving or passing by. So how do you calculate the amount of oxygen that is flowing in the blood? That is the meaning of flux. After it enters the alveoli at a pressure of 99 millimeters of mercury, it enters the blood. So in the blood, at what level or what amount it is being carried out or being taken to up to the tissue level. That is the meaning of flux. So how do you calculate the flux?
So delivery of oxygen equal to cardiac output into hemoglobin into saturation plus bound hemoglobin like 0.03
Very
into
good.
PaCO2.
So it is decided by two factors. One is the cardiac output, another is the oxygen carrying capacity of your blood. Okay. So which element in the blood is very important for oxygen carrying?
Hemoglobin.
Hemoglobin. Okay. Unlike your carbon dioxide, which is mainly dissolved and converted into bicarbonate, oxygen is mainly carried by hemoglobin. So CO2, cardiac output and hemoglobin concentration are the two main important factors which will determine the oxygen flux. So the total amount of oxygen transported per minute is oxygen flux. The definition of oxygen flux is the total amount of oxygen transported by blood per minute. That can be calculated by cardiac output into arterial
Hemoglobin.
oxygen content. CaO2 is content. So cardiac output is 500 ml, 5000 ml per minute, and the oxygen content is 20 ml per every 100 ml. So 1000 ml of oxygen is carried by the blood every minute to deliver to the tissues. So what factors control the oxygen flux? Already we have seen, one is the
Hemoglobin.
oxygen carrying capacity of the blood and the cardiac output. These are the two things which control the oxygen flux. Is oxygen flux uniform for all tissues? Will all the tissues require very high amount of oxygen?
No, sir.
Brain is the most important thing which requires the maximum oxygen. Then comes all other things, isn't it? We all know. So oxygen flux to each tissue bed is not constant, and rather microcirculation responding to altering tissue metabolic demand by varying regional and local blood flow. That is how the oxygen delivery is determined. Which tissue has to get the maximum, which is the tissue which can survive longest without oxygen. When somebody professes to donate an organ, which organ is harvested the last?
Eye
and skin. Okay, they can withstand lack of oxygen for a longer time. Okay, so how much of oxygen is delivered to the tissues is utilized, and what is the oxygen saturation of venous blood? Okay, so total amount delivered is 1000 ml, but oxygen consumption per minute is only 250 ml. Okay, so 1000 minus 250, 750 ml will be returned in the venous blood. So not all the oxygen that is being pumped or delivered to the blood at the pulmonary level is being utilized. So we almost 750 ml comes back. So the venous oxygen saturation should be 75%. Supposing it becomes 60%, what is the importance of that? Supposing you take a venous sample, mixed venous sample from the jugular, and then you do a ABG, and it shows oxygen saturation 60%.
Increased consumption.
Increased consumption or extraction. Okay, that is the important thing. That is the reason why you have to know about this. So, what factors affect oxygen delivery to the tissues?
Hemoglobin, oxygen saturation.
Alteration in cardiac output, arterial oxygen saturation, hemoglobin concentration. Okay, all these three things are. Saturation is also very important, because to calculate the cardiac oxygen content, you have to know about the saturation, which has to be multiplied by hemoglobin concentration, and of course the dissolved concentration is mainly by the partial pressure. So what are the types of hypoxia or anoxia?
Anemic
so if oxygen
hypoxia.
is not delivered properly, you call that condition as hypoxia or anoxia. So what are the types of hypoxia or anoxia?
4 types are there.
Very good. 4 types. What are they?
Anemic
1, 2, 3,
hypoxia,
4.
hypoxic hypoxia, stagnant hypoxia,
Histotoxic.
hypoxia.
Okay. So by knowing these 3 factors, that is cardiac output, the oxygenation, and the hemoglobin, you can have stagnant hypoxia, which is reduced cardiac output or reduced regional blood flow. You can have anoxic anoxia, where FiO2. Supposing you go to a high altitude where the partial pressure is low and oxygen content is low, you get anoxic anoxia. And if your patient is anemic, hemoglobin is low, they cannot carry this oxygen even if your FiO2 is normal, cardiac output is normal, but hemoglobin is only 4 grams or 3 grams, then also anoxia will happen. That is anemic anoxia. And whatever oxygen is taken perfectly by the normal cardiac output, normal hemoglobin, normal FiO2, if tissues cannot utilize it, then it is called histotoxic hypoxia. Okay, so these are the 4 types of hypoxia. Some people also call, these are the 4 common types that you have to remember. And how oxygen is transported. So what is hemoglobin and how is the structure of hemoglobin important?
It has 4 sides of binding oxygen. To bind the first side,
First of all, what is hemoglobin? What is the definition or what is the description of hemoglobin?
Protein.
What protein?
Any heme and globin, 4 globins.
It is a metalloprotein. It is because it has a heme moiety, iron, isn't it? So it is a metalloprotein with 4 subunits containing heme group attached to a globin polypeptide chain. And these polypeptide chains are 2 different alpha chains and beta chains. 2 alpha chains and 2 beta chains. And the type of chains that you have only determine the type of hemoglobin. So if you have fetal hemoglobin, what will be the globin chain pattern?
alpha and delta.
So one molecule of oxygen can bind to the iron atom in the heme group, giving each hemoglobin to transport 4 units of 4 molecules of oxygen. Okay, and the ability to sequentially bind, that is one heme, if it binds to oxygen, it will facilitate the binding of oxygen to the other second heme moiety, then that will facilitate binding with the third and fourth. This is called
Positive cooperativity of.
cooperative binding. Very good. So that also gives the unique sigmoid shaped oxyhemoglobin dissociation curve. Okay. What are the 2 states in which the hemoglobin structures are described before they get attached to the oxygen and then once they get attached to the oxygen? Is there any particular name for their structure or state?
Taut state and relaxed state.
Taut stage and relaxed stage, fantastic. So there are 2 stages, relaxed stage and tense stage or taut stage. So oxygen binding from T state, which is deoxy state, it go to R state, which is oxygenated state. And what are the methods of oxygen transport in the body? What are all the means by which it is transported? Main transport is hemoglobin, which we have already seen. Any other method?
Dissolved forms.
Dissolved form. Oxygen transport directly divided occurring through convection and occurring by diffusion. Features of these 2 methods are convection movement of the oxygen within the circulation occurring through the bulk transport by hemoglobin. And this is an active process requiring energy derived from the pumping of the heart. And diffusion describes the passive movement of oxygen down a concentration gradient from microcirculation into the tissues, ultimately to the mitochondria. Okay. So the CO2 transport in the body. What are the means of transport of CO2?
Bicarbonate.
3 modes you have to describe. I give you the clue also. Bicarbonate is the maximum, then okay. So transported by 3 methods: dissolved directly in the blood, bound to plasma proteins or hemoglobin, and converted into bicarbonate. Bicarbonate is the maximum chemically modified. Protein bound is only 30%. Dissolved directly into the plasma is 10%. Okay. So the chemically modified is converted into bicarbonate and transported. So this is at the tissue level, at the lung level, how it is released from the tissues after aerobic metabolism. So it enters the hemoglobin, binds with hemoglobin. Some part is carried as, what is this HbCO2 called?
Carbaminohemoglobin.
Carbaminohemoglobin. If it is HbCO,
Carboxyhemoglobin.
Carboxyhemoglobin. Fantastic. Very good. So that is the main difference. Carbaminohemoglobin. This is not carboxyhemoglobin. So please remember that. Then CO2 always what mixes with water unstable carbonic acid broken down to bicarbonate and hydrogen ion. Hydrogen ion combined with hemoglobin helps to release the oxygen here. So this is the transport happening here, and the bicarbonate is exchanged with the chloride in the interstitial fluid. And what is that phenomena called? I mean, in the plasma.
Hamburger shift.
Hamburger or chloride shift. Very good. So at the tissue, at the lung level, again, bicarb will enter the hemoglobin, chloride will go out, and all the reactions will change, and again carbon dioxide will be formed, and that will be given out. So the bicarb mechanism is the most important. So remember 3 modes of transport of carbon dioxide in the body: dissolved, bound to hemoglobin, converted to bicarbonate. What is the respiratory quotient of various nutrients that you use? What is first of all respiratory quotient?
CO2 production by O2 consumption.
O2 consumption. Fantastic. Normally, what is the value?
0.7.
0.8. Okay, right. So because 200 ml of carbon dioxide will be produced and 250 ml of oxygen is utilized. That is how you get the value 0.8, 200 by 250. So for carbohydrate, the respiratory quotient is almost 1. So you get 6 molecules of carbon dioxide for every 6 oxygen. And the fat, this is about 0.69. And for protein, you get about 0.9. Okay, so these are all the various. So how is CO2 carried by 100 ml of, how much of CO2 is carried by 100 ml of blood? Okay, each 100 ml of blood carries 4 ml of carbon dioxide from the tissues. And what is Haldane and Bohr effect? Already we have seen that. What is chloride shift or Hamburger phenomena is also what we have seen already. Then comes another important concept of hypoxic pulmonary vasoconstriction. What is this hypoxic pulmonary vasoconstriction and why it is important? Is it a protective phenomena or unwanted phenomena?
Protective.
Protective phenomena. Okay, whenever the alveoli are not ventilated, the oxygen saturation in that alveoli will be high or low?
Low.
Low. So blood has to be stopped from going there, isn't it? So otherwise it will be a wasted circulation. It cannot get any oxygen from there. So what happens? The capillaries immediately go into constriction and prevent blood flowing that, so that it can be diverted to other alveoli which are well ventilated. So this is a protective phenomena to prevent venous admixture. Okay, so that is the answer for that. It's hypoxic pulmonary vasoconstriction, the reflex contraction of vascular smooth muscles in response to low alveolar partial pressure, not arterial. It is the alveoli which has to have a decreased partial pressure of oxygen. So it's an important mechanism for matching the regional perfusion and ventilation in the lung. And what is the physiology of this? The systemic
Diverts
circulation
the blood flow.
Blood flow, already I have told you. But in systemic circulation, usually whenever there is hypoxia, the blood vessels will dilate so that more oxygen can be delivered to the tissues. Whereas in the pulmonary circulation, the opposite happens. Vessels constrict if there is a hypoxia in the alveoli. So it's a protective physiological reflex, divert blood from the hypoxic areas of the lungs to better ventilated area. And the localized high resistance to blood flow promotes diversion of blood flow to lower resistance areas so that well ventilated lungs will get more blood supply. And what is the mechanism leading to that? There have been several important theories that are given. 2 important factors are, one is the low PaO2, alveolar oxygen, and mixed venous of blood oxygen also. So the site of HPV is the pulmonary arterial smooth muscle cells. So they have to go into constriction. And the three components which help in that are biological oxygen sensing, pulmonary arterial smooth muscle contraction, modulation of these responses. These are the three things which result in that. And different theories are there for the smooth muscle contraction to initiate the hypoxic pulmonary vasoconstriction. One is the direct modulation of potassium channels, changes in cytoplasmic redox state, mitochondrial reactive oxygen species production, cellular energy state, alteration of membrane-bound protein, activation of transcription. So all those things are more for your writing your theory exam. So if hypoxic pulmonary vasoconstriction reflex is asked, you may have to write all these possible causes for the smooth muscle contraction and how it can be modulated, what is their effect. It can happen direct modulation through changes in intracellular pH and temperature, or it can be tumorally modulated. Angiotensin II enzyme also will moderate that, and predominant modulation is by localized mediators. And what are the mediators produced by the pulmonary endothelial cells, and what is their mechanism is nitric oxide. It is an important component which is constantly, it is produced to keep the pulmonary vessels in a state of dilatation so that oxygen can be easily taken in. But when the alveolar oxygen pressure drops, what happens? The nitric oxide production is completely stopped. Hypoxia reduces basal nitric oxide production and vasoconstriction is enhanced because nitric oxide causes the vasodilatation. And clinical implications of HPV under general anesthesia, it may lead to whenever some atelectasis is happening because of improper ventilation, then HPV is the one which is going to prevent deoxygenation of the blood. And one lung ventilation, all of you would have known by this time that is very, very important. When we purposely intubate only one lung, the unventilated lung reduces the amount of venous blood coming into the general circulation, mainly by this hypoxic pulmonary vasoconstrictor reflex only. So an oxygen saturation of 90% with FiO2 1 is commonly accepted when you do the one lung ventilation. And in patients with severe COPD, this is supposed to restrict that, but the response is much less compared to normal patients. And in patients with cirrhosis liver, you have a syndrome called hepatopulmonary syndrome. There also, failure of this HPV is the one causing the hypoxemia in the various positions. And respiratory metabolic acidosis, both of them cause pulmonary vasoconstriction. Hypercapnia and acidosis have inconsistent effect on HPV. And alkalosis definitely reduces HPV, and it's more consistent than acidosis. What are the drugs which can affect the HPV? The phosphodiesterase 5 group, sildenafil. Where is it used? Mainly in pulmonary hypertension. That can affect that. Inhaled nitric oxide, that also will cause vasodilatation and aggravate the HPV absence. Nitric oxide reduces PVR, and prostacyclin analogs are used for dilatation and improving the pulmonary circulation. And catecholamines, beta-2 receptors inhibit the HPV response at standard doses. And ABP also causes its effect through vasopressin receptors. And endothelin receptor antagonists are used mainly for treatment of primary pulmonary hypertension, which again will interfere with the hypoxic pulmonary vasoconstrictor reflex. So any patient coming with that particular drug, you have to be careful not to underventilate the alveoli. Acetazolamide is used, as I told you earlier, in the higher altitude. When patients go for high altitude, to attenuate the HPV response at high doses, and it is usually given to make the patient get acclimatized to low oxygen levels in the higher altitude. So this treatment is given to all those people who go to Kedar and Badrinath. Some of your relatives might have gone there. They give it as a pre-treatment before they start the journey. And the AC inhibitors also, they reduce the response. And physiological factors which affect our pH, PCO2, temperature, etc. and precipitate the right heart failure. So too much of pulmonary vasoconstriction and increase in pulmonary pressures can, if it is prolonged for a long time, can precipitate right heart failure. And inhaled anesthetic agents, they inhibit the HPV. And this picture tells you in normal ventilated alveoli, you can see blood flow, pulmonary venous blood flow, which is deoxygenated, meaning coming this way, goes and oxygenated and goes here. Whereas when the alveoli are hypoxic with a low oxygen level, the venous blood coming, vasoconstriction occurs, so the amount of venous admixture is very much reduced. That is how the whole process happens. The drugs which release, now coming, we have finished the some of the physiology and associated common pathological conditions. Last part of the series is the pharmacology of the drugs used. So what drugs are used commonly for relieving bronchospasm or bronchoconstriction? All of you are awake.
Like salbutamol, beta 2 agonist.
Beta 2 agonists are commonly used. Very good. What, by what route?
Inhalation, nebulization.
Okay. So beta 2 agonists are the commonly used drugs. The molecule bind to beta 2 adrenergic receptor. They initiate signal cascade to increase. Ultimately, mechanism of action is cyclic AMP levels are increased, activating protein kinase A, and this acts on the GQ receptors, which decrease the intracellular levels of calcium. So calcium, we have seen earlier, it's very important for the myosin actin uplift, and that is inhibited, so smooth muscles are prevented from contracting. So they dilate, and beta 2 agonists are the first line treatment for respiratory diseases, including COPD and asthma. And they are classified into two groups, short acting and long acting. So short acting beta agonists are called SABA, and long acting. When do you use short acting? When do you use long acting?
Acute episodes short acting, and for maintenance doses long acting.
Fantastic. Exactly the same word I have written. SABAs are used during attacks and exacerbation, long SABA for long-term therapy. Inhaled corticosteroids are the next drugs. So in what way do they help in bronchoconstriction? Do they directly cause bronchodilation?
So they reduce edema and
inflammation.
Edema. Okay, very good. They work by decreasing capillary permeability and lysosomal stability, decreasing inflammatory response at cellular level, allowing decreased inflammatory markers and less mucus secretion. This response allows the airways to exchange more air freely. So there is no direct smooth muscle relaxation effect by corticosteroids. Now xanthine derivatives. Even though not commonly used, yesteryear prime drug was xanthine derivatives when we were students. So how do they act? Which category they belong to?
and
Phenolphylline, deriphyllin. Are you all still using it? Have you used it?
No, sir.
yes, sir.
Yes, some people might be still using it. Okay? So they are called xanthine phosphate diestrase inhibitors. Okay? Naturally occurring xanthines are theobromine and methyl xanthine. Major pharmacologic actions is they tissue phosphate diestrase inhibitors, and they increase the cyclic AMP, which again act through the adenosine receptor antagonists also. They have anti-inflammatory effects, and major xanthine derivatives relieve bronchospasm by caused by asthma and chronic obstructive lung disease. And the most widely used of them is the theophylline. and also have activities mediated through other differential tissues like phosphostasis and platelet function and arterial vasodilatation. They also stimulate muscle and cardiac cells and neurons. This is one of the side effects. Sometimes it can precipitate an epileptic attack also if doses are exceeded. They cause mild diuresis also. So other than this is the reason why they are not now the preferred drug, because of the other side effects that they have other than the respiratory system. They have become obsolete and may have anxiety, nervousness, tremor, headache, and dizziness are also the side effects. So this is the verifilin which is commonly used, which is a combination of etophilin and theophylline. Okay. So it is the etophylline is almost 170 milligrams, and theophylline is about the rest 25 milligrams. So 220 milligrams is the total dose of the drug. 169 plus 50. So then mucolytics are the other medications which are commonly used. Can you name a few mucolytics?
Naproxol.
Commonly, very commonly used. Pulmoclear tablets, all of you would have been knowing about it. Acetylcysteine. Okay, mucolytics are drugs that belong to the class of mucoactive agents, and their function is mucus is the first line of defense for us. It contains proteins like immunoglobulin and glycoproteins, and they are the ones which are helpful. We have already seen how the mucociliary escalator worked in the earlier class. So even though mucus is supposed to be a protective agent, but when they become pathological, they can get infected, they can harbor bacteria and cause pneumonic changes. So at the time, the body may find it difficult to expel that mucus. So we have to loosen it or soften it by drugs called mucolytics. So the mucolytics are classic mucolytics or peptide mucolytics. These are the two classifications. N-acetylcysteine is the common classic mucolytic. Then carbocysteine, then iridosteine and pseudosteine. These are all the four classes of classic. And peptide, dorsinase alpha, thymosin B4. And what is the mode of action of NAC? This is how it acts. It reduces the disulfide bonds to sulfhydryl bonds, preventing the cross-linking. So the mucus does anything which is cross-linked. Your clot during coagulation also, the fibrin has to be ultimately cross-linked to become a unbreakable compound. So cross-linking is a natural phenomenon by which a product can be stabilized or made strong. So by preventing the cross-linking, it can make it breakable easily, increase sputum portability, reduces sputum viscosity, and it causes a better clearance. Another method is it reduces inflammation and oxidative states, decreases expression of mucus, and also decreases sputum hypersecretion. So all these things lead to improved post-expiratory volume, less dyspnea, and lower addition of bacteria and lower exacerbation rate. Any other use of this N-acetylcysteine, which we have seen?
Paracetamol toxicity.
Paracetamol overdosage, fantastic. How does it help in that situation?
It replenishes the glutathione stores.
Glutathione stores are replenished. Fantastic. Very good. Very good. I am happy that you remember all that. Right. So that finishes our discussion on the basic sciences of respiratory system. Started with anatomy and ended up with pharmacology. So this is what you have to remember at the various stages of respiratory system. So more or less, I have tried to cover all the requirements for both from theory answering as well as for practical exams and OSCE. I have tried to balance the presentation. So any suggestions or any omissions you find in this? Any doubts you have to clear?
No, sir.
No, everything is very clear. I find some new name, Yogesh. Who is that? It's a new PG.
Not from me, sir.
Not from here. Okay, right. Right. Dr. Kamachi is there? He is also somewhere. Okay. So for next class onwards, shall we start discussing theory questions? Mutupriya,
Yes, sir.
Yes, sir.
Abhigami?
Yes, sir.
So I will send the questions to you in advance. You have to prepare the answers, and we will discuss them, and we'll see how your preparation and my corrections help you to make a better answering of your theory questions. Okay.
Okay,
So
sir.
it will be same pattern, but because you have 4 papers in your